Well, hello, everybody. Good afternoon or good morning. My name is Garrett Schmidt, and I am the CEO and managing editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by WellSky. And this one is called Strategizing for Team Success, a cross-continuum guide to smarter episodic management. A few items of note before we get started. This is a traditional webinar format, so everyone has joined today in listen-only mode. So this means you don't need to turn off your mic or your camera. We can't see you or hear you at home, but we do want to hear from you. We are going to have a time for some Q&A towards the end of the presentation. So if you have a question at any point for either of our speakers or just in general, you can use your attendee module to ask those questions. We're going to get to as many as we can today. We've got a lot of content to cover. But if we don't get to yours for some reason, don't worry, someone will reach out to make sure that we get your question answered via email later on. The session today is being recorded, so what's going to happen is when we conclude, maybe about an hour or so after we're done, you will receive an email, and there will be a link to the recording as well as to where you can download the slides. And I'm sure you'll want to do that because, again, there's a lot of material for us to cover today. So without further ado, I want to briefly introduce our speakers today. With us, we have Ms. Bridgette McGrath, who is the COO of WellSky Payer in Emerging Markets and the PAC Advanced General Manager. And also Tommy Gotreaux, and he is the Director of Solution Architecture at WellSky. So I'm going to turn it over to you two at this time. Welcome.
Thanks, Garrett. Appreciate the time and welcome, everyone. Thank you for giving us some of your time today as we talk about what's coming ahead that CMS is pushing with us with team. So as we'll go, through the next couple of slides, as Garrett said, would love this to be interactive. Hear your questions, hear your thoughts, where you are on your journey. So to level set, really, talking about team, what is team and the goals that team's hoping to accomplish, it stands for Transforming Episode Accountability Model. This is really a model that CMS has chosen these specific DRGs listed out here, these 5, the coronary artery bypass graft, the lower extremity joints, which includes hip, knee, and ankle, major bowel procedures, surgical hip femur fractures, and spinal fusion. They've included those DRGs or HIPSPICS codes that you can see that we've outlined there for the total cost of care management to hospitals. But what's different is they're really including that 30-day post-discharge expense within that one set price that CMS is going to set as a target price. Participation will start in January 26, so it's just around the corner, and that will run through December 31st, 2030. Really the ultimate goals that CMS is hoping to accomplish with as they start moving towards, value-based care, higher quality outcomes, smoother transitions of care from the acute through the post-acute, and really then hopefully ultimately enabling equitable patient health outcomes so that there is a quicker recovery after these surgeries with fewer avoidable hospital admits and ED admits, and with you having visibility through the care continuum of how you can partner with your post-acute care delegated entities or vendors you work with to ensure that your patients are taken care of that fall underneath this team program. So what's included in this program, we'll go through in the next slide, is, as I was saying, not just that inpatient stay that normally is covered by that DRG, but it's included in the post 30 days post-discharge is the post-acute care services. This can encompass inpatient rehab, long-term acute care, skilled nursing facility, home health, and hospice. Any patient readmitting within that 30-day episode, that is included of any other outpatient services. Certain Part B professional services and drugs are included under Medicare, and then clinical lab services and all DME within that 30-day are also included in this episode. So it really is a comprehensive episode from that anchoring DRG, whether that's in the inpatient or outpatient, through that 30-day post-discharge, inclusive of all these incremental services that are now covered under that target pricing. So I think next we're going to hand back to Garrett to do a poll for us.
Okay, yeah, we've got a interactive session here today, and you were going to see on your screen a question. And the question is this: what best describes your experience with value-based care or bundled payment programs like Team? This is anonymous, by the way, and we're going to have several of these throughout. And we'll show the results here. So we'll give it another few seconds for folks to answer. And again, the choices are: I am new to the concept of team, have some exposure, but I'm still learning, continue or currently participating in a similar program, or deeply involved in strategy or operations. And again, this is anonymous, but it'll help to show kind of where you stack among your colleagues and see kind of what's how people are feeling out there. So results are still coming in. We'll give it maybe another 5 long seconds and then close it down here. 5, 4, 3, 2, and 1. Okay, Bridget and Tommy, are you able to see the results on your screen?
Yeah, we
Yes.
are.
You
Yeah,
may
this
want to
is
read
kind
those
of
out for those who are calling in.
sure. So, as Garrett said, the question is what best describes your experience with value-based care or bundled payment programs like Team? New to the concept, we had 17% of the audience, some exposure and still learning, 50%, which I think that is what I would expect, is that, new on this journey and still learning, finding out what this is going to mean for you. Currently participating in a similar program. Exciting to see that there's so many already participating in a program. That was 14%. And then deeply involved in strategy operations, 19%. So excited to hear from you what's working, what you've thought through, and if anything that we talk about today and then in the upcoming minutes we have together can add to that strategy operations. I'm glad to hear that some people are already deeply involved in operationalizing these. So thank you for sharing those results with us. I'm going to hand over to Tommy.
Thanks, Bridget. So now we'll spend a few minutes talking about building your team strategy and really kind of diving into the first few slides will be kind of an overview and then we'll get into some more specific details. But one of the important, pieces of this is knowing who the team patients are in order to start proactively planning and make sure that you are, appropriately planning for the next best site of care. Having the entire care team aware of the identification of these team's patients will be important. And so we took a look at the DRGs for the inpatient stays and then the HCPCS codes for the outpatient stays. And one of the things that's a little bit different, from the bundle payment model, as some folks may have been participating in that historically, is a number of these procedures will likely be scheduled and ahead of time, you will know and have that information on those patients. So making sure that you are identifying those patients early and it's visible to the care teams so that the care managers, social workers, population health teams will be able to proactively engage with the patient and family and ensure that the patients are sent, to the highest quality, lowest cost next site of care. If it's appropriate that they need a post-acute level of care, or even if they can go home, with services or maybe home on their own. So surfacing those eligible patients and just having clear visibility across your care team is important. And then I briefly mentioned, but really diving into the proactive discharge planning. So knowing that the patient is a team patient, is great, but then making sure that you set appropriate expectations with the patient and family post-procedure about what is going to be the best next site of care for them, ensuring that they get the care that they need. And a lot of folks think, oh, I have to go to a facility in order to be successful in my rehab, but really setting those appropriate expectations, based on the patient's status prior to their surgery will be important, and managing those expectations, on the backside. So educating the family and making sure that they're aware, and then sharing that information and coordinating care early on with your post-acute partner. So making sure that the post-acute partner is aware that this patient is part of the team model. And that is, if they are part of a collaborative network or high quality network that you're working with, or otherwise, just making sure that they also have clear visibility will be important to make sure everyone's on the same page when providing care for the patient. And then finally, really coordinating across the network. So we'll talk a lot about high performing PAC networks, and it'll be really important that your organizations are focusing on those high quality, low cost providers for managing that 30-day bundle price cost, and cost point to make sure that you're meeting that target pricing, or hopefully, coming in below that target pricing so that you're successful in the model. And then again, making sure that those post-acute providers are aware that this is a team patient. So really visibility, driving that proactive discharge planning once you know that the patient is part of them, and then making sure they're a part of that network, going to that high quality network will be really important. And then next, we'll talk a little bit more about really driving success in the team model and some of the specifics about building and maintaining those high quality post-acute networks. This is going to be key to your success. And so making sure that you have, not only the CMS data, because we know that CMS data can be lagged. Sometimes they're not getting a new survey for, 9, 12 months, and that star rating isn't up to date and isn't, the most recent information. So having real-time performance data will be really important to understand, well, how is this provider performing in the last month, 3 months? Have they improved their quality? What's their cost looking like? And making sure that you have that visibility to build out those networks will be important. The next piece is shared incentive models. So Team does allow you to set up some shared incentive programs with providers, and to make sure that they are bought into the concept and are on the same page and participating with you. So that is something you can absolutely do. Explore gain sharing agreements with those strategic high performing partners so that they feel like they have some skin in the game, and they will put forth the same effort that you are to manage these patients and share that accountability. Now, next is monitoring that performance in real time. So we know from the previous experience in the BPCI bundle payment program, as well as some of the others, the data, the quality data, your performance data is going to be really lagged when you're getting that back. So you really need to have some visibility into real-time performance for your post-acute partners, but also around readmissions and that sort of thing. So having access to real-time data, if we're talking in the post-acute space around length of stay, rehospitalization, readmission data, is really important. And then that can enable you to have teams that are actually working with and proactively managing the patients while they're in the skilled nursing facility if they need that level of care. And beyond the skilled nursing facility, also understanding home health and the utilization of home health, and are we having timely start of care? One of the highest likelihoods of readmission is that transition period. And so if you have an agency that isn't getting out there to see that patient within the first day or 2 days of discharge, then that's increasing that likelihood of rehospitalization quite significantly. So having visibility into that data in real time and being able to monitor that performance and then share that performance back with your post-acute providers will be really important. And that really comes to point 5 is, having those actionable partner metrics and the visibility on the partner side so that they can see that information along with you and not have to rely on you to share that or send that information over. So ideally, you would have a platform where, the contributors of sending data would also be able to see their performance on your team identified patients, and that's something that here at WellSky we can help you with. And so it's really important, to have that cross collaboration and in real time where your providers are bought into monitoring their performance. All right, next slide. So now when we're thinking about, we talked about building the network and early identification, and now how do we operationalize all of this? So it's really going to start in the acute setting, be that an acute inpatient or ambulatory setting. And making sure that you have the appropriate PAC episode management, making sure that you have the visibility of the patients, you're setting them up for the right level of care upon discharge with a high quality provider. You have teams, if they need to go to the SNF, that you can monitor them and work collaboratively with that SNF to manage length of stay and manage the likelihood of rehospitalizations. And then when it comes to transitioning from that post-acute stay, if they need to go to a facility level of care back to home, having that visibility of when they're going to be discharged, making sure that you're doing timely outreach upon discharge from that post-acute network or post-acute partner to outreach the patient and make sure that they have what they need. If they have home health ordered, has home health been out to see them? Were they able to get their medications filled? So all of those things will help prevent readmissions, which can drive up your 30-day spend. And then, keeping an eye on that and understanding the financial metrics and models based on that performance, will be, important in monitoring your overall financial performance and how you're doing. And then ensuring timely follow up with that PCP because, you're going to be responsible for the 30-day bundle, but you're not always the person that's in front of the patient. So ensuring that the PCP is getting engaged, that they are aware that the patient is part of the team model and are, actively participating in that. And the overall goal of the operational model, such as this, is improved outcomes. So having better financial performance, making sure that your clinical teams are plugged in to this operational model. And then with all of that high touch and engagement with the patient and family, improving that patient experience. And this is something Bridgette will touch on a little more here in a moment. But, if you guys don't have the teams in order to do that, WellSky has a clinical support model that Bridgette's going to dive into. So just a preview on that, but she'll expand on that here in a moment. And so next, we're going to go to another poll and kind of see what everybody's thinking on this one.
All right, just as before, we're going to go ahead and bring this poll up on your screen. And if you're joining us a little later, these are anonymous and it's just for fun. And we're going to show the results here to kind of see where you stack among your colleagues. The question is, which of the following are part of your current care management efforts? Is it performance tracking across PAC providers, use of referral workflows or scorecards, risk stratification or readmission monitoring, none of the above, or non-applicable non-acute provider? So I believe this one is you're going to select all that apply. And we're going to wait for the results to keep coming in here, and maybe in about 10 seconds, we'll go ahead and shut it down and show the outcomes here. And it looks like most of the results have come in, but we're going to give it about another 5 seconds, and then we will bring it down. Trickling in. They're neck and neck here. All right, so we'll show the results in just a moment. All right, we're going to close it down in 5, 4, 3, 2, and 1. Okay. Tommy, are you able to see, Bridgette, are you able to see the results here?
Yes, yeah, we can see them here. So to recap and kind of cover where everyone stands, which of the following are part of your current care management efforts? And it looks like folks are quite engaged in a lot of these activities, which is exciting to see. So the first one, performance tracking across PAC providers, had 43% of folks are working with that information. Use of referral workflows or scorecards, 52% of respondents are on board with that. Risk stratification or readmission monitoring kind of wins the overall prize here with 67% of people responding that that's part of their strategy. We had a few folks, 16%, that said none of the above, and then about 10% of folks that said not applicable because they're not an acute provider. So a little bit, of a mixed bag, but I think, overall it's great to see that folks are, by and large, hitting on a lot of the buckets that we talked on. So that's exciting to see, and you all are setting yourselves up for success here, which is great. So thanks for your responses there, and we'll have one more here in a minute, but we'll keep moving and kind of get into some of the specifics about actually managing that 30-day episode, visibility, transitions, and risk, just kind of building on what we have talked about before. So on this next slide, you're going to see some information around real-time surveillance. So I talked a little bit before about ensuring that you have visibility, to the patient, not only while they're in the acute or ambulatory setting, but then, through that post-acute stay and beyond once the patient is home. So, there are a number of solutions, but one of the solutions out there that can help you with this is our WellSky CarePort Connect solution. Can empower your care teams with real-time visibility and help the teams proactively manage the patients for the full 30-day episode. So starting in the acute care side or the ambulatory setting, we mentioned flagging those patients and having that visibility while the patient is having their procedure and during that inpatient stay. For that real-time visibility, ensuring that your patients are flagged and your care management and social work teams are aware. So, one of the solutions that the CarePort Referral Solutions offer is flagging those patients proactively and putting that in front of your care teams. So when care planning is occurring, that you will have that visibility into that. And then beyond the acute, the Connect platform is also going to track those patients into the post-acute space and help enable you to have better care coordination conversations with your collaborative partners in the PAC setting. So there's embedded real-time chat that will allow you to chat with post-acute care coordinators and care managers to ensure that the patient is getting the care that they need, and if it's needed, that someone from your care team jump in to help. Having that ability to securely collaborate will be really important. And then the next is driving risk warnings and letting the team know that the patient is, maybe going off course, that there's something going on with the patient that is putting them at risk for a, hospitalization now that they're in the SNF. Having real-time visibility into activity in the SNF, be it a view in the EMR, and being able to see provider notes through the post-acute EMR, but also having vital signs pulled into the Connect solution from the EMR and having risk flags around that. Are all part of the solution offering that can help your care teams really manage that patient when they're in that post-acute setting, making sure that you're monitoring and keeping up with length of stay, but also preventing those rehospitalizations, which are all going to drive up your cost. And then finally, focusing on that provider network. We've talked a lot about this, but you all understanding and knowing the provider network is great, but being able to share that out with other members of the care team, even in the post-acute space, by, through an integrated platform, and having that visibility around these are the providers that are part of the network, and these are the providers that have performed the best for these patients in the specific, in the team bundles, will be important as well. So kind of that cross-continuum management all the way from starting the, initial pre-hospital planning for the surgery in the event that it is a pre-planned surgery, identification, cross collaboration with the post-acute, and then making sure that you're sharing that visibility to those high-performing providers, even with your post-acute partners if they need to refer the patient out beyond that initial stay. So kind of that cross-continuum management. On the next slide, we'll talk a little bit more about managing that transition and minimizing risk as the patient is being, having discharge planning, but then also once the patient is discharged from that setting. So patients are most vulnerable, I mentioned already, at the time of transition, and your highest readmission risk is at that time. So some key points to ensure success during that initial episode of care. begin the discharge planning as early as possible, at the point of, the pre-op workup, if it's a um, scheduled procedure, sorry, or making sure that if the patient if it's unexpected and they're an inpatient, once you see that flag, making sure that they are ready for that next level of care, that next site of care, and being able to share that information and set appropriate expectations will help with your patients. So again, the attribution flagging, making sure that there's visibility to those patients, and then the next piece is making sure that the patient has the authorization for the next level of care, and that you're not having any sort of holdups there. Not as big of a deal, and with team and being that it's a Medicare, but making sure that they have everything that they need for those patients for that next level of care transition, and then sharing that care plan, setting appropriate expectations with your PAC provider. So again, highlighting that, for the PACs, they're not part of your acute network. They need to understand that this is a team patient. So sharing that information on the referral, sending them any sort of, high quality network list when they are looking for their next site of care after a post-acute stay in a SNF, if they need home health care, for example, making sure that all of the providers are aligned, that there are seamless handoffs, and that you're all working, toward the same goal of high quality, low cost care for these teen patients will be important. And then the next piece is preventing readmissions. So, a lot of this information will be making sure that you're sharing the information, but also having those touches with the patient during those transitions of care. And so understanding when the patient goes back to the hospital, if they do, so an example, if the patient is discharged from your facility, maybe they went home with home health, and then they show up at the ED. In order for you to potentially mitigate an unnecessary observation or inpatient stay and drive up that cost, you've got to have visibility that the patient showed back up at another provider. Maybe it's your system, or maybe it's somewhere outside of the system. So getting real-time alerts around those transactions will be really important, so that your care team could reach out to the ED and say, hey, this is a patient that we're caring for as part of our team model. They're plugged in with our primary care doc. If they don't need an observation or inpatient stay, we can get them in the office maybe later today if it's in the morning, or tomorrow morning, to give that ED care team confidence that the patient's going to get the care that they need. So those real-time alerts and having that visibility will be important. And then also we talked a little bit about predictive analytics, understanding that risk. Is the patient at a high risk for hospitalization once they've hit the SNF, or post-discharge, so that you can proactively plan. Maybe you have a number of patients on your panel and you want to start with those highest risk patients, and making sure that you're having touches with those high risk patients. So that will be important as well. And identifying any other early warning signs. We mentioned the vital sign risk, and those things will be important as well. And then having visibility into that post-acute stay is great, and managing that patient proactively, but then also ensuring that post-acute is also on board, as I mentioned before, and tracking their performance for utilization, rehospitalizations, making sure that they are getting the feedback, hopefully through a platform in real time that they can access themselves, or that you're sharing with them for that feedback loop, to make sure that everyone's on the same page and there's accountability across the network for success. So now I'm going to hand it back over to Bridgette and let Bridgette talk a little bit about our WellSky clinical operations offering that can support you with your team initiatives.
Thanks, Tommy. And wanted to share a little bit about what we've done on the clinical operations side that we have operationalized today for various value-based programs with partners like yourselves. Think of these that even though we can be an extension of your team, these are tasks that we have found really drive greater outcomes, whether it is your operations team that complete it, or we partner with you, or you partner with another entity that can absolutely help you make sure that you have this operations layer on top of all the important points that Tommy's pointed out: the visibility, the high-performing network, the care coordination from acute to post-acute, the prevention of the readmissions. So when we talk about layering clinical operations on. It's really collaboration of identification. Firstly, keeping that home first mentality in mind, that can we get, let's use Mr. Clark in this case, we're going to do a little user story on Mr. Clark, but can we get Mr. Clark home safely? And then we work and we educate hospitals on high performing post-acute care networks. Because of the robust analytics we have, the visibility to millions of discharges, we're able to really isolate post-acute care networks that are within your geography that you refer to today that perform better for certain DRGs. And especially there's a great opportunity now with team being restricted to those very specific DRGs to identify a high-performing network that you want to collaborate with. Today we collaborate with you to add in consult of admission requests or unskilled facility returns. So if somebody is in the emergency room, that we can say is, Mr. Clark recently was at a skilled facility, let's get him back there, does not need to be admitted. It's a same cause readmission. And ensure there is that care coordination happening between a post-acute, whether that's a warm handoff for high acuity patients that you may want to do with your post-acute care providers, whether that is a follow-up with a robust discharge summary if you can't do the warm handoff, but really showing that your post-acute care providers have visibility and have a complete comprehensive picture of the clinical presentation of your patients in these value-based bundles helps them to be able to better take care of these patients. And then the targeted post-discharge outreach based on risk stratification for the patients that are going home, the higher risk we engage with more frequently. We aim to engage with everyone within 7 days post-discharge, and then from there establish the cadence through the 60 or even 90 days if needed to ensure that the patient stays safely in home, they have the care that they receive in the home, that they have all their services set up, and they understand the next goals, their PCP appointment, that home health will be coming, the importance of maintaining their therapies. Lastly, talk about an ED transition program. This is really a program that what happens when you get that notification or that one of these patients is now back in the ED that is part of a value-based bundle like team. What do you do with that? Can you then work with your post-acute care network to safely discharge them back home or to a skilled facility if initially we thought, Mr. Clark could go home. We realized Mr. Clark gets home. He's not able to manage the stairs. He comes back to the ED. Can we get them into one of your high-performing networks? So really having that close collaboration with your ED for these patients that are in the team model. Then if Mr. Clark does need to go to a skilled facility, making sure that there is a progress review during Mr. Clark's stay, whether that's you proactively engaging with that skilled facility or partnering with someone, and we can bring operations to that as well, that a progress review is done halfway through the stay to make sure that Mr. Clark is tracking safely to his discharge date, there's no barriers to care, and all the discharge have been set up. This is done through IDT round participation in the skilled facilities, really focusing on the rising risks, the targeted length of stay, patients that may qualify for hospice or any barriers to discharge, and then coordinating again, as Tommy pointed out, that very vulnerable time when they're discharging from the SNF to the home, making sure that those discharge activities are coordinated. So when that discharge happens, we want to make sure that home health and other services are in place. There's a coordination with the patient and the patient's care team. So we want to make sure that the patient is also looped into their goals and their care team as well. That could be a loved one, someone that they're going home with, or a caregiver that we need to be ensured that also understands the patient's care team. And then as I spoke about those ongoing outreaches for the 4 weeks post-discharge to ensure that you're addressing escalated risk, any SDOH needs, follow-up appointments are completed, including medication adherence and any clarity that they need around their discharge instructions or any follow-ups. So when you're thinking of layering extended operations outside of the hospital, it's really important to partner with your post-acute care facilities or your post-acute care entities that are out there, whether it's home health, your DME providers, or an operations team that is stood up to manage these patients post-discharge. So I think with that, we're going to go into a story. We're going to speak about Mr. Clark that we spoke about, which is a case scenario that we'll go through. And I'm sure all of us know a Mr. Clark or have been a Mr. Clark or have a family who's a Mr. Clark. That, we're going to use Mr. Clark, who's a retired school teacher who really loves to dance. Mr. Clark, then we're going to go through these slides pretty quickly because they're really short. But unfortunately, he fell at home last week, fractured his hip, and needed admission. So this was an unplanned admission. He falls into the team bundle because he has a fractured hip. The care team uses WellSky today to support and enhance Mr. Clark's journey. And we'll talk about how that happens today. If we go into the next one, thanks, Kelly, is Tommy really hit on these. Sorry, Kelly, go back one. Tommy really hit on those. Thank you. Tommy hit on these really. I'm not going to go into great detail on all of them as Tommy went through them in great detail, but really all the things we're speaking about are the care management and how that's done through AHR, patient engagement, discharge planning, or workforce management. Care transitions, that could be the intelligent referral management, which is to those high performing providers based on that DRG, making sure that it's an appropriate setting and then managing that network, coordinating the care with the alerts, the notifications, so that you have visibility to where your patient is in that care journey, making sure that care is coordinated, hospital to home, ED, home health. You will have complete visibility so that you understand that. And then making sure that care plan is reflective to address any SDOH, but ultimately back to a new level of function or prior level of function as appropriate based on that patient, that their visibility. And then optimizing services, whether that's through your coding and billing to make sure that you've accurately captured that DRG is part of the team model so that you understand, does Mr. Clark fall into that team model? What does that look like? What is the RCM on that? And any clinical protocols you need to pull into place and technology as well to support you and your team. Underpinning all of this is value-based analytics. Tommy also touched on some of the analytics that we provide, but really that real-time analytics based on Mr. Clark, that he's all the way from him falling in the emergency room to getting admitted, and we'll talk about his journey some more, getting him safely home, that you have the analytics visibility and not waiting for those claims that come in that are really lagged and often delayed. And then it's almost too late to have those true insights that you can then are predictive and act on. You can then act on because they're so predictive in nature that you can provide those unique layer of insights that are value-based through all of these different settings, from managing the care to coordinating the care for Mr. Clark. So did want to touch on that, on really the underpinning functionality that you look to deploy to manage these team models or any value-based programs. So we'll go back to Mr. Clark now, and you can go to the next one, is really thinking about the connection of care, that Mr. Clark is admitted, and as of now we know Mr. Clark was admitted, we begin his transition plan when he is admitted and the first day post-surgery. We know Mr. Clark is part of the team model. If you go to the next slide, Kelly. There we go. Because of the attribution we have, we know that Mr. Clark is part of the team patient model. Unfortunately, Mr. Clark cannot go home because he has stairs at home. He's had a hip fracture through his fall and he's unable to negotiate the stairs. So he's discharged to a high-performing skilled facility based on his DRG. Mr. Jones meets his targeted length of stay in the facility through all of those factors we spoke about, that monitoring. You have that visibility to the rising risk, the progress reviews that are performed in the skilled facility. Mr. Clark is able to meet his targeted length of stay. I keep changing Mr. Clark to Mr. Jones because that's what I normally speak about, Mr. Jones, but we're not forgetting Mr. Clark. So Mr. Clark meets his targeted length of stay and then he's stable enough to go home with home care services. Once Mr. Clark is home, we know that DME was ordered. We can see that it had arrived in his home and that the home health nurse was scheduled to be with him within 24 hours post-home because he had a really short and targeted length of stay based on he had very little minimal complications. He was a retired school teacher who loved dancing that just had this untoward event of a hip fracture that needed skilled facility really for that stair climbing training, not really anything else. Once he achieved that, we knew we could get him home safely, provided we could bring home health into his home. So we wanted to make sure that Mr. Clark had everything he needed at home, his DME, his rolling walker, and that home health had arrived within 24 hours of him discharging home. So making sure that all that care is coordinated for Mr. Clark to have a successful episode that is really the best outcome for Mr. Clark, but will help you manage towards that target price, especially when you lose visibility of Mr. Clark discharging from the hospital into the community through the skilled facility back home, that you have that visibility into Mr. Clark's journey. Is it tracking? Is it coordinated? And are you able to manage his care? So you're going to the next one, Katie. So we do talk about that 7 days post-discharge appointment, that then ultimately we want to make sure that Mr. Clark also understands his instruction, his caregiver does, and we can close any gaps in care at this point to ensure that we've addressed any rising barriers, any SDOH needs, or any questions he may have, because we all know at time of discharge there's multitude of discharge instructions coming. Which medications should he still take? Should he take the ones he was previously on? Should he add the new ones? We really want to make sure that that care is really coordinated and he has all his follow-up appointments. So through this, really what we're aiming to do, and I believe this is the right thing for any patient like Mr. Clark, is the right care at the right place at the right time. And now with the support of home health, Mr. Clark will recover at home safely and able to go hopefully back to his dancing as a retired school teacher. I believe we have another poll.
We do. And I am pulling this up on your screen. Okay, where are you in your team strategy journey? And this, again, if you're joining us late, these are anonymous, but just kind of give you a feel for where you sit among your colleagues. Are you just learning? Need more information? Are you actively shaping your team strategy? Are you ready to evaluate opportunities? Or are you already implementing or optimizing? And looks like the results are coming in, so we'll give it a few more seconds here for folks to answer. And I've gotten several questions about whether these slides and recording will be available. And yes, they will absolutely be available, and you'll be receiving a link to where you can download those slides and rewatch the recording at your leisure. So it looks like most of the results have come in. I'm going to go ahead and close it down here in about 5 seconds. 4, 3, 2, 1. Extra long 5 seconds here. All right. Bridgette, Tommy, are you seeing the results?
We are. It's very interesting that when asked where you are in your team strategy journey, that 50% are actively shaping, which I'm really glad to hear. Often we are talking to other audiences and they're like hearing team for the first time, and I think with CMS recently releasing targeted prices, and I think more and more we're hearing more and more inbounds about how to strategize and operationalize teams. So great to hear that there's 50% of you actively shaping your team strategy. 33% of you are just learning and need more information, which is also, not surprising, that probably received some of the CMS pricing targets and what does this mean and what's included in that. Ready to evaluate opportunities, which is also, exciting to be looking now at what opportunities there are and what's out there to help you identify those opportunities, whether you're learning, actively shaping, evaluating, or already implementing. Where are the highest opportunities based on your performance historically and your target pricing for you to think about your team strategy. So really more than I expected to see already actively shaping the journey. So that's a positive sign that's happening out there. So nice to see that. Garrett? So we'll go into the next slide about how how we can offer you potential solutions really on any of those, wherever you are on your journey for team, whether that's operationalizing, thinking through it, evaluating opportunities, looking at your data. We spoke about the surveillance, the readmission solution, and the post-acute care solution. So outside of the technology and clinical services operations solutions, we really have a program-specific opportunity analysis that we can bring to you that really is informed by CMS, claims data, and preliminary target prices. So I think that, what we've done is we've taken the monthly claims by CMS processed during the performance year, and then we have predictive analytics that can also help you forecast as well as help you with your reconciliation. Whether you decide to deploy, enhance your current processes to manage this, whether you decide to deploy your own technology, partner with somebody like us, use our operations to augment your team or not, it's really important to understand where you're starting at and your areas of opportunity, how to look at this data, and understanding that the complexity of it can be a little bit overwhelming. So want to show you in the next slide how we could bring to you an opportunity analysis. So think about this is we would come in and help you have a look at this by hospital, by DRG as well. So you get episodic specific cost driver insights, the opportunity prioritization, and then the estimated savings potential. So what we want to do is demonstrate and visualize for you here is if you have a look at the graph on the left-hand side, that is your baseline spend that historically to date, what has been performed, that index hospital stay, what's the spend from readmissions, the spend from post-acute care or skilled nursing facility, and those buckets we spoke about, the DME, the professional, the medications. CMS has now released a targeted price, which you can see there is reflected by the $25,000. And then we're able to show you the average regional spend that is occurring within your region. With your particular data, what we can then show you is where your areas of opportunity are. So in this case, looking at this example, you would say that readmissions are a high area of opportunity for this hospital if we ran this analytics for you. That really the skilled facility stay, and in that we include inpatient rehab and LTAC, is probably what we would expect to see at national benchmark. So probably this hospital already has a high-performing network, closely partnered with their facilities, but there's a potential for a readmission program and more focus to be applied on readmissions. So really having a look at your historical spend, where the spend was, the new target pricing that CMS has put out there, the regional average spend, and then areas of focus to be able to help you get towards your targeted price and obviously want to go below your target pricing. So did want to share our deep analytics model that we can bring to you that's really customized based on the aggregate team data, identifies your financial risk, variation, and your post-acute care performance, as well as those areas of opportunity. So I think with that, that was the last one. I think, Garrett, back to you for any questions we may have.
Okay, yes, we do have some audience questions. And by the way, if you have a question that you would like to ask either of our speakers, go ahead and use your control module as an attendee. You have a specific place for questions that you can use. So drop those in there. We're going to get to as many as we can. If we don't get to yours, though, don't worry. Someone will make sure to reach out via email. Okay, in no particular order here. First question is this. You mentioned the importance of early identification. How are organizations using attributions to surface team-eligible patients before admission?
Yeah, I can take that one. From a technology standpoint, speaking specifically about the WellSky technology, we have a dynamic rules engine where we can ingest, before your patients that are scheduled. So outpatient ADT information saying for a pre-op visit or pre-op scheduling appointment, knowing what that HCPCS code is if it's outpatient or upon admission from the DRG perspective, getting that initial or working DRG will be really important. And so in our technology solution, we have a rules-based engine that we make sure that the patient meets all of the criteria to fall into the team model, and then are able to apply that attribution flag starting in the referral platform, early on, and then as well as, as the patient moves into the post-acute space, pushing that over into our Connect population health management tool so that there's clear visibility into that. So we use a dynamic rules engine to surface that attribution and make sure that there's clear visibility across both for your organization as well as any of the post-acute organizations that are contributing data and working with you.
Gotcha. Okay, next question is, what are some best practices you've seen for managing transitions of care to reduce readmissions during the 30-day post-discharge window?
You want to take that one, Bridgette?
Yeah, sure. Happy to take that one. So I would say probably best practice is understanding the risk profile of the population. If it's, a Mr. Clark, that's relatively low risk, minimal comorbids, and he had an unexpected fall, compared to understanding a risk profile of a patient that's admitted that has multiple comorbid conditions, is then putting additional touch points around that patient with the higher risk profile through those transitions from acute to post-acute, whichever setting that may be, and then touching base with them through the 30 days, but also understanding that they may need additional support or may need to reach out if there is a way that they can proactively engage and have a resource to engage with. Either in the hospital setting, you may have a care coordinator, a patient care coordinator, or a member services lines that you really educate them on. If you have any questions, please reach out to us, and that you can then help them navigate anything that may come up. So ensuring all the things we spoke about, so I don't want to repeat all of them, but really the post follow-up visits are set up, that the patient's aware of them, that they're going to the highest performing provider, that there's early warning signs they're educated on, and then also somewhere for them to engage. And again, especially for those high risk members that you identify, but not forgetting the lower and moderate ones, at least doing one touch point to make sure that they're still maintaining a low risk, that something didn't happen or they didn't understand a discharge instruction. So having a touch point with all of your members and patients that are in these value-based team models, reaching out to them, engaging them, and then ensuring that they have everything they need around them to support them in the community, to keep them safely at home, and even leaning on some of your community-based organizations that are out there as well that can help support these patients. So it really is an important one, especially now that it's included in this team model, and it's one of the highest drivers of the total cost that will impact your performance against your target pricing, is really trying to make sure you focus on those readmissions.
Wonderful. All right. Next question here is, can you share some examples of how hospitals are using data to identify and partner with high-performing PAC providers?
Sure. Tommy, you'll take that one.
Yeah, I can take that. So obviously utilizing the CMS star ratings, that's an important piece because that's data that is available to everyone across the board. I will say the one kind of challenge with those star ratings is the timeliness of when they're updated, and so we know that the surveys only happen at best once a year, hopefully, and so that information isn't most up to date. So using real-time data and also focusing on the DRG specific episodes, cost of care and length of stay is really important. So having that visibility will be helpful. So an analytics tool that is able to pull in that real-time data and show you patients more focused on that short-term or rehab benefit that the patients are having, because the CMS star rating tends to be skewed towards long-term care. So having that short-term care visibility is really important. Understanding utilization patterns. So what is the average, length of stay if it's a SNF? What is the, their rehospitalization rate? Not only readmissions, but how often are they sending patients to the ED for care and those sort of things? And so that's all going to come through a real-time analytics platform that is getting that data fed from the post-acute EHRs. And so having that information at hand, through some of the WellSky tools or other tools out there will really help you formulate the best post-acute care network that you can, by really digging into that data. And then ensuring that the partners are engaged. So making sure that if you're selecting that high performing network and building that network, not only looking at the data, but making sure that the organization that you're hoping to work with is on board and will participate in your interdisciplinary rounds and also have a seat at the table to provide that seamless care. So, the data is very important, but having an engaged partner is equally as important. So I think, those are some of the key things in really looking at and focusing on the data piece and the real-time data and utilization metrics.
Makes sense. All right. I think we have time for one more question here, and then we will close out. So this last question here is for organizations just starting to explore team. What are some practical first steps to begin shaping a strategy or evaluating opportunities?
I can start, and then Bridgette absolutely jump in. I think the first thing is understanding. So looking at your historical data and trying to understand, what sort of volume are we looking at, and then, beyond volume is understanding your cost structure. So, where is our spend? If you have the ability to do that level of analytics, if you have an analytics team, pull some of that historical claims data, look at the different buckets, what are the pricing that we're seeing for the inpatient or outpatient stays, and then the drug pricing, and, really trying to hone in on those specific buckets to identify your areas of opportunity. I think also looking at it not only by surgical volume, but look at your provider and their performance, the individual, physician performance itself. Patterns of referrals and things like that become very ingrained in physician practice. So understanding, hey, does Dr. Smith always send his patients to a SNF for some inpatient rehab? Is there ability to influence him and having him focus on moving those patients into home, home health with therapy at home and things like that? So the first thing is really just understanding the data on your historical performance. And then grabbing that, the data that CMS recently sent out at the beginning of June around your target pricing, and then compare where you are. And that's going to set you up to understand, okay, where do we really need to tackle? Are we way above our target pricing? And then you really have to drill into the areas that you need to focus on. And if it happens to be things like readmissions, those are something that you can't really control within the hospital. So that's when you need to start thinking about your strategy around how are we going to manage these patients as they discharge from the transition of care and then through that 30-day episode. Do we have the capacity to layer that on to maybe our primary care teams that are following these patients? Do we need to set up a centralized team that's operating out of the hospital? Or do we need to partner with an organization that can provide clinical services like Bridgette outlined? I think is a great place to start and really wrap your hands around kind of what you're looking at and where you are. Bridgette, anything else to add there?
I think you summarized it great.
Perfect. Well, unfortunately, we are out of time. And again, if we didn't get to your question or weren't able to ask your question, don't worry. Someone will make sure to will reach out to you via email to get your question answered. But as we close out, first of all, I want to thank you, Tommy, Bridgette, for a fantastic presentation. There was obviously a lot covered here. We're going to be sending a recording, or a link to the recording rather, after this, about an hour or so after. You'll receive that, as well as a place where you can download the slides. But as we close out, I wanted to encourage you all to head over to VBC Exhibit Hall. Oh, wait, actually, before we do that, there was an announcement about People in Purpose Care Forum here that's going to be happening in September. The information for that will be in the slides for you to download, so if you'd like more information on that. But again, as we close out, if you want to head over to vbcexhibithall.com and check it out. There's a lot of great resources there, but one of them is the WellSky virtual exhibit booth. And there will be, again, a link to this directly in the slides. And you can read up on them and what they're doing in the space and some of the resources that they provide and really educate yourself on them. And then, of course, reach out to them through there. I'm also happy to facilitate an introduction if that's easier. And you can just reach out to me. But also the webinar will be archived in our library there, as well as all the other webinars that we've done for WellSky, so that you can find that in our archive library at vbcexhibithall.com. And then finally, if you would like to reach out directly to the WellSky team, their information is on here, cn-general@wellsky.com. And again, I'm happy to facilitate an introduction as well if that's easier. Thank you all so much for joining us. Hope you have a wonderful afternoon, and we'll see you on the next one. Bye-bye.